Welcome to Making the Most of the Golden Half Hour. My name is David Woodruff. I'm the president of Ed for Nurses, where we empower nurses to become extraordinary. What you're listening to today is part of our 2-minute EBP challenge. Every Friday, the question goes out, and you have an opportunity to answer the question over the weekend. Out of the correct responses we receive, we take one of those and enter it into a drawing, and we have a drawing for prizes every week with our 2-minute EBP challenge. On Monday, you get the answer to the 2-minute EBP challenge. As the name implies, this has to be quick and easy so that you can get information quickly and easily and take it back to your practice. Also, you might want to check out our 101 Nursing Tips. This is a Google group. You go to groups.google.com and you can find 101 nursing tips. This would be the opportunity to be able to share tips with each other, and I'm also sharing tips with you on this nursing group. Okay, today we're going to talk a little bit about that golden half hour in our patients who are having acute coronary syndrome, and this begins here with the problem that's on the underlying problem of acute coronary syndrome, which is atherosclerotic disease. So what's showing here is a picture of a normal artery on the top, and then an artery with a patient who has atherosclerotic disease, and you see the plaque is forming there, and we have a decrease in blood flow. So that's the underlying problem that we're talking about here today, and how we are going to best respond to that in our patients. Now, acute coronary syndrome is this grouping of different problems that occurs in our patient. The underlying problem is atherosclerotic disease, and then you put it on a continuum, and we can see we move through this continuum from stable angina to unstable angina, non-ST segment elevation MI, and an ST segment elevation MI. So that's our non-STEMI and our STEMI. So what's happening is we're moving from maybe a smaller clot or a smaller obstruction up to bigger, until we're getting necrotic damage to the heart. Another way to think about this continuum is to think about it on the left as ischemia. We move into the middle, now we're getting into injury. Over to the right, now we're getting into necrosis. So ischemia, injury, and necrosis would be another way to think about this process that's occurring in acute coronary syndrome. Well, we want to be able to prevent the patient from getting over to the right. We want to keep them over to the left so that they are not getting necrotic damage to their heart, which can lead to long-term complications like heart failure. So we want to keep our patients away from there and over on the right side. How we're going to do that is by having real good prompt treatment for our patient. Well, the preferred method of treatment would be percutaneous coronary intervention. This includes stent placements and angioplasties, those kind of things. So that would be preferred. We send the patient down to the cath lab, and we are able to do these interventions right away, reopen the vasculature, and then the patient doesn't get as much ischemic damage. Well, if we can't do that, we have the possibility of using thrombolytics. Thrombolytics are medications that break down clots, and hopefully they're going to break down the clot and revascularize the heart. Thirdly, if neither one of those two options seems viable for this particular patient, then we would consider CABG surgery, so open heart surgery, cardiac surgery. Let's take a look for a moment at this whole idea of PCI, percutaneous coronary intervention. Now, what happens with percutaneous coronary intervention is we have a plaque, as illustrated here, and the plaque is narrowing the vessel. The physician sticks a catheter in the femoral artery, goes up through the vasculature, gets to where that plaque is, and inflates a balloon, as shown here. So the balloon is inflating, it's compressing that plaque up against the sides of the vessel. That's called an angioplasty, and you see how it reopens the vessel? This gives the patient the opportunity to be able to have an improvement in blood flow. Next, we can also put in a little cage device in there, and that cage device is going to help to hold that vessel open for an extended period of time. That's the stent placement. So that is the stent. The stent is going to hold that vessel open over an extended period of time so that we don't get some compression there back onto that vessel. Another possibility, as I mentioned before, is thrombolytics. Thrombolytics are going to help to break down the clot. So here we have the vessel that is obstructed, and you can see that no blood flow is getting past there. So what we're going to do is we're going to give a thrombolytic, as such as TPA, that's going to go to that clot and break down the clot. It literally breaks the clot down and will revascularize the area. Now, that is a good initial intervention, especially if the patient presents to a rural hospital where they don't have PCI available. The third possibility then would be that we do CABG surgery. And this is just a couple pictures here, the before and after when they've done CABG surgery on your patient. So you take a look at the after, and what they did is they took the right internal thoracic artery and they grafted it to the vessel that's obstructed, and the saphenous vein graft to the vessel that's obstructed. So what we're doing is we're bypassing the obstructed vessel, and we're putting some other vasculature, attaching other vasculature to that area, so we're revascularizing the heart. Well, the American Heart Association recommends that we have 30 minutes from the time the patient presents to the emergency department until we transfer them to a facility that will have PCI available. So that was the current recommendation. In this study, they found that only about 9.7% of hospitals met the goal. The median time of transfer was 68 minutes, and about 31% of our patients were transferred 90 minutes or later after they presented to this rural or to this outlying hospital that did not have PCI available. This translates, a delay translates into a 51% increased risk of death in your patient. So we don't want to have that delay occur. In the study, they also found that there was a number of other variables that contributed to delay. Age, so the young patients who presented having acute coronary syndrome, maybe we thought, well, maybe they're really not having an acute coronary syndrome, but at any rate, it caused an additional delay of 18.3 minutes. Presentation at a rural hospital caused a delay of about 15 minutes. Female sex caused a delay of about 9 minutes, and contraindications to fibrolytics caused about a 7-minute delay. You would think it would be just the opposite. If the patient had a contraindication to fibrolytics, they would be transferred quicker, since we didn't have the option to use fibrolytics in this case. So the recommendations from this group are, rather than having our focus be on transfer, maybe our focus should be on providing the thrombolytics and then transferring. In fact, these authors suggest that we even give the thrombolytics on the ambulance. So we start training paramedics to give the thrombolytics en route to the hospital so that we can decrease the delay even further. So their recommendation is maybe we need to change the focus. The focus has been on a rapid transfer. That hasn't happened. Maybe what we ought to do instead is to give these patients thrombolytics at this outlying hospital instead. She says the speaker was rushed to the hospital with chest pains. Apparently, he has an opportunity with high blood pressure. Okay, well, hopefully our patients are not going to have an opportunity with a bad outcome because we don't know about these findings. When a patient presents to the emergency department with chest pain and acute coronary syndrome, we really want to get that treatment to that patient within the first 30 minutes because heart is muscle, or time is muscle. And the more time that goes by, the more muscle that's going to be affected. Now, if you'd like to find out more about this study, you can pull the article here from the Archives of Internal Medicine, Dr. Heron and colleagues. They wrote the national performance on door-in and door-out time among patients transferred for primary percutaneous coronary intervention. You can also get nursing tips right on your cell phone. If you text to 86677 and put in the body of your text nursing tips, you will get nursing tips weekly to your cell phone. Okay, I understand some people pay for their texting service, so we don't abuse this and send you lots and lots of texts, but I will send you a text every week with a nursing tip to help you to improve your practice. Thank you for joining me this week for Making the Most of the Golden Half Hour. My name is David Woodruff. I'm the president of Ed for Nurses, where we empower nurses to become extraordinary. Join us online by going to www.edfornurses.com. Thanks again for joining me this week, and until next time, bye now.